emergency just in case.
You got it.
All right, I'm out of here.
Okay. Good morning. If I am not, if you can't hear me, just raise your hand, tell me to speak up. And if I say something that doesn't make sense, please slow me down. Most of these slides are new slides, are different. This is not a talk I've given a lot before. And that's one of the nice things about Myeloma Crowd. They often ask you to talk about things in a different way or the next level of conversation. So I'll be interested to hear your thoughts and any questions. So risk is a lot of what this talk is about. And we'll start off with the risk of developing myeloma. So if you have more than one first-degree relative who has myeloma, you have a significant increased risk. If you just have one first-degree relative, your risk is about fourfold increased. Now, on a scale that's concerning, fourfold sounds like a lot. But remember, the risk is approximately 4 to 8 per 100,000. So if you increase that by fourfold, it's not a significant absolute increase. If you have Gaucher's disease, not very common inherited disease, your risk of myeloma increases significantly. Age is a very important risk factor. My youngest patient was diagnosed at 15 years old, had a thoracic compression fracture that was biopsied, reviewed by the pediatric pathologist who had not seen myeloma in about 20 years and misdiagnosed it. They had no idea what type of cancer it was until they showed the adult hematopathologist who realized it immediately. African Americans about twice as likely as Caucasians to develop myeloma. Now, risk is a difficult word because myeloma docs use the word risk in multiple different ways, and then we don't understand why you don't get what risk is. And so it's a frustrating thing. So let me just break it down. If we say you have high risk monoclonal gammopathy of undetermined significance, a precancerous condition, and we ask you to please come back in 3 months, that means that risk is all about your likelihood of developing a blood and bone marrow cancer, multiple myeloma. So risk there is the likelihood to develop cancer. But on the other hand, later in that same day, potentially in my clinic, I could be talking to somebody who says, because of your high-risk disease, we will always need to treat you with 3 and even 4 drug cocktails. Now there, 2 things there. Number one, we somehow all the time slip in the word disease rather than myeloma or cancer. That's one of our favorite synonyms that we tuck in there so you don't understand what the heck we're talking about. And there, high-risk disease or high-risk myeloma stands for less likely to respond to treatment, shorter duration of response, and more, and in essence, a shorter overall survival. So you don't want to have high-risk myeloma. And other one is your only lytic lesion is in your skull. So your myeloma bone disease is low risk. There, risk is thought to be your likelihood of developing a fracture because for the vast majority of us, your head is not a weight-bearing part of your skull. Occasionally, you feel differently at work, but sometimes that's basically the case. So, and lesion. Lesion is another one of our favorite terms that excludes you from the conversation. Lesion means abnormality. That's all it means. So when you see lesion on any radiology report that you see on my chart or our portal, it just means that it's an abnormality. And in myeloma, that usually means a hole. So in the setting of myeloma, with the actual blood and bone marrow cancer, risk means that you're more likely, low risk means that treatment is more likely to be effective with an average overall survival somewhere between 8 and 12, sometimes longer. And whenever I give overall survival, thoughts here, it's basically as if time stopped now. And all medical research stopped at the moment. And you just think, what would happen now if you were diagnosed and we could learn no new information? That's obviously not happening. Medical research is ongoing. Clinical trials are ongoing. FDA drug approvals are continuing to percolate along. So we give these overall survivals acknowledging that the overall survivals have doubled in the last 10, 20 years each in myeloma. High-risk myeloma, again, more difficult to control. Treatment is less effective, and these patients have a shorter overall survival. So when you are a myeloma patient and you are newly diagnosed, I want you to think about what type of myeloma you have. You have low-risk myeloma, high-risk myeloma, and that often in myeloma is about stage. And we're going to talk about our use of the word stage and how the rest of the world uses the word stage. So our use of the word stage is all about what type of myeloma do you have. Do you have stage 1 or low-risk myeloma? We define that, or we used to define that when this was initially published from the Mayo Clinic, based on 2 blood tests, beta-2 microglobulin and albumin. You have a low beta-2 microglobulin and a normal albumin. That means you have stage 1 disease and longest overall survival. Stage 3 is a high beta-2 microglobulin, more proliferative myeloma cells, more of them being made per minute, per second, per day. These patients are less likely to respond to treatment. So before treatment, we want all patients to have a beta-2 microglobulin and an albumin done. Now that was back in 2005, and that's since been revised. This is the 3rd staging system, and it's called the Revised International Staging System. Oncologists love to tell myeloma patients, well, your stage is 3B. And the myeloma patient says, well, what staging system are you talking about? What are we dealing with here? And it's very difficult to know, but there are 3 staging systems that are in use that people talk about. This is the most current, and here it combines the international staging system on the left. You see the criteria here of the 2 lab values, beta-2 microglobulin, albumin. And for genetics, that's related to the abnormalities seen on bone marrow biopsy, along with an additional blood test called LDH, or lactate dehydrogenase. And this system together, between the blood criteria and the genetics, overall helps you figure out whether patients are low risk, stage 1, high risk, stage 3, or sadly enough, stage 2, which is I don't know. It doesn't necessarily mean you have intermediate risk disease. It's really I don't know. And these patients are often linked into those that are misclassified and actually low risk and those who are actually high risk. But at the time of diagnosis, we just don't know what we're dealing with. And that happens to 60% of myeloma patients at diagnosis. Sorry? Okay, so the word stage depends on context. And talking with patients over the years helped me understand this. When a patient with lung cancer, colon cancer, prostate cancer, breast cancer, when they go to their oncologist and the oncologist says, you have early stage cancer. Stage in that sense means location. You have stage 1 or 2 cancer. It's isolated to a small part of whatever organ, the lung, the colon, breast, whatever. And it usually means that a surgeon can cut it out and there's a high likelihood of curing that cancer. And it means that on the life cycle of the cancer, it was found earlier on, before that cancer could spread. Stage is synonymous with location. Your cancer is metastatic. Well, that means there's stage 4 disease. My favorite statement from my myeloma patients is, my oncologist told me I have stage 4 myeloma. To which I often answer, what the hell's that? And so for metastatic cancer, where normal oncologists, stage is location. It's metastatic. It's spread throughout your body at diagnosis. This makes no sense in myeloma. This makes no sense in leukemia because your myeloma is spread throughout your body at the time of diagnosis. So location doesn't mean anything. It's everything about how risky or how chemotherapy responsive the cancer is. And that is how we use the word stage. It's different than how everyone else in the world uses stage, unfortunately. And also it's irritating because when patients come back and they're like, okay, did we stage my disease? I was like, no, we didn't stage your disease. We did that 3 years ago when you were initially diagnosed. We don't restage your myeloma because it's not particularly meaningful. So when I say we expect you to have easier to treat myeloma, I mean you have stage 1 myeloma. Or when I say just like 60% of my newly diagnosed myeloma patients, I don't know whether you have easier or harder to treat myeloma. That means you have stage 2 myeloma, very unsatisfying stage. And we expect you to have harder to treat myeloma. That means you have stage 3 myeloma. And that's how we use the word stage in myeloma. So stage and risk, not only do we use these words, for risk we use them differently, for stage we use them differently than every other oncologist, there's also the idea of control. And control is how when most oncologists talk about with breast and colon and lung cancer, when they talk about stage, we talk about control. And what we mean is that your myeloma is under control. That means that there are fewer myeloma cells now, usually, than there were a month ago, or coming under control, or that there's no new myeloma cells now, based on lab tests from a month ago. So you can see on the left-hand side, there's no new cells, and that means your myeloma is in control. At that point, if your myeloma is in control, your myeloma is not going to significantly cause you the cardinal symptoms, fractures, anemia, and kidney failure, what myeloma is known to do. Where if you go to the right-hand side of this slide, where it talks about out-of-control myeloma, there's more new myeloma cells each and every second, each and every day. So you're more likely to develop fractures, anemia, and kidney failure. So control is what we're always trying to look for in patients with treatment. So can we enumerate control? Yes. So my favorite patients, I got to tell you, are engineers and accountants. Engineers and accountants love them to death because they love numbers. And my life is all based on numbers. Everyone's very excited to know their IgG, their monoclonal protein, their kappa light chains. All these numbers, they dominate my life. And they dominate my patients' lives. And where prostate cancer, again, cancer for men, it's just one number. Got to be simple. Men cannot handle more than one number. And for myeloma, no, we're not simple. We're 3 different numbers half the time. Some of the time 2 numbers, some of the time just 1 number. Oh, so complicated. And so whenever you're thinking about what is the status of your myeloma, start thinking about what are my numbers? Where are my immunoglobulins? Where is my monoclonal protein? Where are my light chains? What is the most accurate indicator of the status of my myeloma? Whatever that is, that's on the vertical axis here. So any one of those 3, and sometimes do all 3. And my accountants and engineers, they literally create graphs. They're looking at Fourier transforms. They're doing slopes. I mean, it is the best. So anyway, if you have myeloma and your myeloma is percolating along but not causing you trouble, you will be in a linear phase of your myeloma. That's where there's more myeloma each and every day, but it's unlikely to cause you significant symptoms. But when the slope of the curve changes, rise over run, this spot here, right here, this is when you're more likely to have symptoms. And when the slope increases dramatically, that's when my patients develop fractures, anemia, and kidney failure. So in an incurable cancer, where do you want to treat patients? Well, you don't really want to treat them here. They're tooling along. You're treating a number. You want to treat them over here where you're going to provide value, where the symptoms and the side effects of treatment are going to decrease the likelihood patients are going to develop fractures, anemia, and kidney failure. So do you relapse differently if you are low risk? If you have low risk myeloma, this period of time here can be quite a long time. This can be months, this can be years. This is not a bad time for a clinical trial because that's when you know the train's coming down the tracks, you know you're going to need treatment, but your back is not against the wall. You don't have a creatinine or kidney function is cut in half. You don't have a new fracture. You are asymptomatic, but you know you're going to need treatment very sometime soon. This is a good time to think about a clinical trial. How's that different than if you have high-risk myeloma? If you have high-risk myeloma, everything just got shrunk. So you have very little time from, hey, I think your myeloma is active again, to, hey, why is my creatinine 3? And all of a sudden, you're back against the wall and you absolutely need effective therapy immediately. And the difference is that in patients in high-risk myeloma, they're always should be thinking about new and novel therapies, but they absolutely, you can't say, come back in 3 months, I think everything will be fine. You need short interval follow-up between visits, especially when their myeloma is becoming active. Okay, this is my busiest slide. This is complicated. It's difficult to understand. And I'm putting it up here just to sit with it for a second. You can come back to these slides, but I'm going to take you through it one by one. It's not as bad as it sounds. So on the top, you can see MGUS. This is a precancerous condition. Treatment, we generally don't treat MGUS. We have a clinical trial here in Atlanta looking at the microbiome, looking at modifying your immune system to try to change your risk of developing myeloma. Low and low intermediate risk myeloma, mostly observation. Again, there are clinical trials that can be thought of. Patients with intermediate and high-risk smoldering myeloma, or patients with monoclonal gammopathy with plasma cells that are disordered, that are causing the patient trouble, but they aren't fractures, anemia, and kidney failure. They could be a weird type of kidney failure. They can cause coagulation problems. They can cause skin problems. Things where plasma cells are being naughty, then they should be punished. And for that, you need some type of plasma cell-directed therapy, and mostly it's related to the same drugs you use in myeloma. And there's the Revlimid and dexamethasone, Cybor-D, etc. All those are usually less aggressive treatments trying to kill plasma cells. At the bottom here, don't worry about all this gobbledygook. This is basically patients who have high risk, intermediate risk, standard risk, and we have basically, you can think of it as different levels or different amounts or intensities of treatment, trying to stay at pace with what kind of patient, what kind of myeloma the patient has. And certainly happy to go back to this at a later date. So, hold on here. Okay, so first-line therapy, I'm just giving this to you as a way to think about myeloma, the risk, and how treatment is considered. If you have myeloma and you're thinking about what should I do initially, well, I put 3 random options here. They're not a comprehensive list. Somebody who has newly diagnosed myeloma can get Revlimid and dexamethasone, RVD, KRD. These are all reasonable treatments in newly diagnosed myeloma. You might expect with best therapy 30 months of disease quiet. Let's say you did that and you got your 30 months. And now you're thinking about second-line therapy. You did the RVD, you developed neuropathy. Well, now what do? What's your next second line of therapy? And here you could do Pomalyst and dexamethasone, Darzalex, Pomalyst and dexamethasone, or KPD on the right-hand side. And that's going to provide you a shorter period of time of disease control, but there are numerous options. Let's say you do that. You did Dara-Pom-Dex. That kept your myeloma under control for 18 months instead of 20 months. Now what are the options? Well, these are many of the same types of options here. Again, it's a little bit of an error to have Dara-Pom-Dex on the same slide. Sorry about that. But this is Benda, Pomalyst, and dexamethasone, KPD. And finally, you're thinking about fourth-line therapy. And so here, this is somebody who had Dara-Pom and Dex. Then they had Kyprolis or carfilzomib, Pomalyst, and Dex. And they ended their 9 months of therapy with a pulmonary embolus or a PE. Now what do? Now we're getting fewer and fewer effective drug cocktails, and likelihood of disease control a shorter and a shorter time period as the disease goes from whatever they were at diagnosed to more and more difficult to control. And I listed out some options here at the bottom.
Good question.
Yes?
So I see you have Pomalyst. I mean, they were previously exposed to Pomalyst and progressed.
Yes.
But then it's still listed in combination with these other,
Yes.
the newer drug.
Right.
So that's still.
Isn't that annoying?
Still like it's still.
I agree. Shouldn't we have totally different drugs?
But it still shows activity.
Right. It depends on, even if you've had, and one of my colleagues, Dr. Nuka, has has published on the idea that if you've had dara and dexamethasone, Pomalyst and dexamethasone, and you've progressed on both of them, and then you get dara, pom, and dex, you can still get a 30% response rate. So yes, it's not ideal. Yes, we should be always using new and different drugs with fewer side effects, but we can't always get there, and I wish we could. I am going to skip these slides here, and I want to quickly talk about myeloma bone disease. So myeloma bone disease myeloma is not modern, really. It's been around for thousands of years. You can see evidence of it in skulls from archaeologic digs, this one from Sudan. And myeloma bone disease, again, what you don't want to see is holes in your bone. Your parents' admonishments that you don't need a hole in your head is absolutely true. And 90% of myeloma patients do develop bone lesions at some point in time. Many of them have bone pain. And normally your bone, something that I didn't really realize, is that your bone is in a constant state of flux. You're always laying down new bone, you're always taking up old bone. And you do this at a very rapid rate when you're 18 years old. And when you're 70 years old, you do this very slowly. And that's important because and when you're 70, you're more likely to pick up old bone than lay down new bone. And that's not the case when you're 18. And in myeloma, there's always spots where you're picking up old bone on the left, laying it down on the bottom left, and on the top right, you can see you're trying to take out old bone, but in myeloma, you don't lay down as much new bone. So you're picking up a lot more than you lay down related to where the plasma cells are. And these guys, the osteoclasts, they pick up the bone. The osteoblasts, they lay down the bone. And in myeloma, it revs up the osteoclasts and it destroys that balance. And so you're picking up old bone, and the osteoblasts are not able to lay down new bone. What Zometa does through a mechanism of essentially infiltrating the actual bone is it makes both the osteoclasts less able to pick up old bone and osteoblasts less able to make new bone. It kind of strengthens the bone by heading in there, but it allows the bone to decrease the patient's risk of fracture. And Xgeva essentially starves these osteoclasts of energy, this monoclonal antibody that is more strong than Zometa. So the ways you deal with fractures, primarily compression fractures in my patients, but if you have myeloma in your hip, in your arm, these spots can be at risk of fracture whether weight-bearing or not. And there's a lot of things that we need to think about, a lot of ways to deal with these myeloma bone disease. Some of them involve injecting cement directly into the bone. And on the right side, this is direct injecting cement, but after a balloon is placed in the vertebra, and then the cement is injected and allows the bone to be less likely to necessarily get worse. Neither one of these things are repairing as much of what you might think, but they certainly do decrease pain and improve function in the majority of patients who undergo this. Again, this is a large rod that can be placed to stabilize long bones like your femur, below your hip and your humerus. And overall, there are medications we can use to improve bone strength. So your bone stabilizing effects is here. Calcium and vitamin D doesn't really have much bone stabilizing effect, but oral bisphosphonates do it a little. Zometa given yearly does it more. Xgeva given twice yearly does even more. These can be done in patients with osteoporosis, whereas in myeloma, you need a lot more bone strengthening medications, and you can do Zometa monthly or Xgeva monthly. So Zometa and Xgeva both decrease the fracture risk, but they don't prevent all fractures. They don't build new bone. And their old bones that have been chewed up from myeloma don't heal faster because you're getting Zometa and Xgeva. They just decrease risk of new fractures. Again, it's my second busiest slide. Hang in there. It's going to be okay. You're almost done. Just like 20 seconds left. So Zometa reduces fractures in patients with myeloma who have myeloma bone disease, and if the disease is aggressive. If the disease is a pussycat, the Zometa doesn't really help that much, and the same goes with Xgeva. For patients with, that's it. No. Hold on one second. My brother uses that with the kids, and that's all I can think of is, playtime's over, screen time, I'm done. Cut off. So Zometa is primarily for patients with myeloma bone disease who have aggressive cancer that's not well responsive to treatment. So for newly diagnosed patients, giving IV Zometa makes certainly good sense. Xgeva is basically equivalent to Zometa, but it causes less kidney damage risk, more low calcium, and sometimes that's quite symptomatic, and slightly more osteonecrosis of the jaw. And that's when you have an area of your gum that basically melts away and exposes bone underneath. And the biggest risk for osteonecrosis of the jaw is much similar to Ohio, is not seeing your dentist very much. So trying to have regular dental visits so that you don't need a tooth pulled. And especially what we don't want to have is somebody getting Zometa or Xgeva and then needing to have their tooth pulled. And at least if that absolutely happens, and you can't avoid it, then there's some things you can do with some chlorhexidine mouthwashes to decrease your risk of osteonecrosis of the jaw occurring, because you don't want that difficult and painful condition. Okay. Thank you very much for your time. If you have questions, comments, please feel free to email me. And if you want to see these slides again, they're online. You can get them anytime. They're on Google Slides, and I'll update them as I get better thoughts. But please feel free to use that tiny URL link. Thank you very much for your attention.